Hello, my name's Ian McCall. I thought what we'd do tonight is have a little look at some of the cases of linear IgA disease that are in Global Skin Atlas, and we'll also look at a little bit at histopath and treatment. The thing that's important about this condition is that there are two separate age groups in which it can occur. There's this case here that occurs in childhood, called chronic bullous disease of childhood, and the more typical adult linear IgA disease. Now, we'll look at some of these images here first. This was a lady who presented with some blisters and excoriated areas on her buttocks. You can see some of the blisters still out here, these areas of excoriation. Now, she was initially diagnosed as bullous pemphigoid, and she had been treated with high-dose steroids for many years without really good control. The question as to whether she had had a biopsy done before, she probably had, and it was probably just an ordinary H&E biopsy. And immunofluorescence probably wasn't done, because when we saw her later, we did do another biopsy and direct immunofluorescence, and it showed IgA in a linear pattern on the basement membrane, and not the IgG and C3 that you would see in bullous pemphigoid. Let's just have a closer look. The classic feature, though, are blisters that occur on a red base. And they're usually intact blisters as well, because the separation in this condition is through the lamina lucida. So they usually will heal without scarring, but they're like bullous pemphigoid. They occur as intact thick-walled blisters on a red base. The other thing that's important to remember, though, with linear IgA disease is that it can also be seen as a drug reaction, particularly to vancomycin, a drug that's used to treat severe multi-resistant staphylococcal infection, and also to captopril, which is a drug used to treat hypertension. Let's have a look at the histopathology of this condition. I think we'll look at this one. These are from Path Presenter. So this is an intact blister. You can see that it is a subepidermal blister. In other words, the whole roof of the epidermis. The epidermis here makes up the roof of this blister. This is the dermal. These are the dermal papillae here. There's edema here. The cells that are in, these are red blood cells. Remember, in bullous pemphigoid, you would be looking for eosinophils. Now, in linear IgA disease, you can sometimes see eosinophils, but you're more likely to see neutrophils. And often those neutrophils are in the dermal papillary space as well, in a milder form, so that they can look a little bit like dermatitis herpetiformis. However, when you get splitting like this, this is much more the picture that you'd see in linear IgA than in dermatitis herpetiformis. In drug-induced bullous pemphigoid, eosinophils are often the predominant cell in the inflammatory infiltrate in this space. If you do immunofluorescence studies on this and do salt-split skin, usually the IgA is in the roof of the blister. Sometimes it can be in the base, and that's because linear IgA disease is a heterogeneous disorder. There are various antigens that are attacked, including the bullous pemphigoid 180, and in some cases, it's even the collagen 7 that's attacked, and that's below the lamina densa itself. So you can get varying patterns just reflecting the varying nature of the heterogeneous nature of the antigens attacked in linear IgA disease. Let's have a little look at some of the other clinical cases that we have here. I'll do these adult ones first. This is another 76-year-old patient with linear IgA disease. This lady had been on vancomycin for an infected hip prosthesis when she developed these blisters on her elbows, dorsal of the feet, buttocks, lower abdomen. And in this one, it was linear IgA with neutrophils in the blister cavity. Now, we said before that sometimes vancomycin will have these eosinophils in the blister cavity, so it can look a bit like bullous pemphigoid. But let's have a look at these mixture of blisters here, isn't it? Some of them don't appear to be occurring in the red base, others do appear to be occurring in the red base. They're intact blisters. So the thick-walled means it's deep split. Let's have a little look here at the abdominal wall. See, this could almost be the pattern of prebullous pemphigoid. You know, you've got this diffuse erythema. And if this was prebullous pemphigoid and you biopsied that, it would show eosinophilic spongiosis. It won't show that in linear IgA disease. What else do we have? Again, just a reflection of that deep dermal erythema that you get, deep dermal hypersensitivity-like reaction that you can get linear IgA disease as well. And the other cases that we'll look at, let's look at this one, because this is the classic for linear IgA disease in children. And it's then called chronic bullous disease of childhood. And if we look at this, this is a classic feature. There's a little ring of blisters around the outside of the lesion. Sure, some of them are burst here. There's crusts. Sometimes there's hemorrhage into these blisters as well. But again, you've got these intact blisters on a red base. And it's the peripheral location here. Look at the others up here in the groin, around the genital area. Let's have a look at some of the other images of this. Here we go here. Symmetrical nature of it again, red background, blisters, intact blisters in the red background, and sort of rings of blisters. Similar pattern here. Crusting, a bit of secondary infection there as well. Now, this was a 4-year-old boy, 7-month history of a vesicobullous eruption on the lower limbs, buttocks, and the face. Multiple clear round vesicles, Boolean erosions, marked erythematous background, and a string of pearls, cluster of jewel signs. The oral mucosa wasn't involved, but the oral mucosa can be involved in this as it can be in linear IgA disease. The Zank smear is looking to see if there's virus, herpes virus. Now, this little boy's treatment was with dapsone, and a lot of linear IgA disease will respond to dapsone. Remember, there are neutrophils involved as well, and dapsone is quite useful for neutrophilic disorders. And dapsone itself is very useful for dermatitis herpetiformis. In fact, it's the drug of choice. Thing about this condition in children is that usually it will burden itself out. In other words, sometimes by the age of 10 to 12, the condition will just burn itself out, even when it occurs early on in a 4-year-old like that. This is a section in Medscape on linear IgA dermatosis, and this is just an example that they have in children. Again, often around the genital area, again, intact blisters on a red base. This was drug-induced, and it's curious to see blisters like this in the palm of the hand. But this was vancomycin-induced, and it was linear IgA disease. There is a variant of bullous pemphigoid that can present just like this as well. So you can see how difficult it is to make a definitive clinical diagnosis. You really have to excise a blister with a bit of surrounding skin to do your immunofluorescence studies. Remember, it's the surrounding skin that's the important part, because the the deposited immunoprecipitants may be damaged underneath the blister area. You may not see them as well. So it's the skin adjacent to that that's important to examine. It's interesting. These were the some other drugs that may be associated with linear IgA disease: amiodarone, ampicillin, captopril we mentioned. I think the vancomycin is easily the most common one that you can see this condition. You can see some of these other drugs here that have been reported as causing linear IgA disease. And even infliximab, a TNF-alpha inhibitor, usually used to treat psoriasis, has indirectly perhaps caused that. Some of the PD-1 inhibitor drugs that are used in melanoma, they can, melanoma metastasis, they can, by unleashing the immune system, unlocking it, can often precipitate certain immunobullous diseases as well. I've seen a case of EBA, and it wouldn't surprise me if a linear IgA bullous dermatosis might come out in a patient on those sorts of drugs as well. It's interesting there. Linear IgA associated with, in 5% of cases, with underlying malignancy. So Hodgkin's disease, non-Hodgkin's lymphoma, chronic lymphocytic leukemia, some solid tumors, bladder carcinoma. So yeah, you've got to keep that in mind as well when you see a case of linear IgA disease. And also in association with these other autoimmune disorders, these associations may be coincidental. This was the last of the clinical cases that we have here, 10-year-old this time. Look at the extent of the blistering. Big intact blisters. There is a background redness there, but it just gives you an idea of how severe the blistering can be in this condition. I mean, bullous pemphigoid can occur in children, but it's very, very rare. Mind you, this condition isn't common either, but it's certainly more common than bullous pemphigoid in children. Just a quick look at the other images. Again, that ring of pearls, of blisters around the outside of the involved areas, is such a characteristic feature. Cluster of jewels, string of pearls. Okay. Linear deposits of both IgA and C3. I must admit, it's more IgA rather than the C3. You know, IgG and C3 is the picture that you see in bullous pemphigoid with immunofluorescence. I'd also advise you to have a little look at the dermatology online. It's probably one of the better resources if you want to do a search for some of these diseases and some of the variations that you can in fact get in this if you're looking at the histology, especially the immunofluorescence picture. So you can see there's a wide range of articles here on this condition. So, as I say, we've got some good images here in Global Skin Atlas, and I hope that gives you a better idea of the histology of this condition and the treatment essentially with dapsone. With oral steroids can be used, but they're not the primary drug as they would be in bullous pemphigoid. Thanks very much.